And today I would like to welcome my co-chair, Professor George Follows, who will have to run away and will be replaced by Dr. Nicholas Martinez. So firstly, we'll concentrate on cardiology. In hematology, we have to be more acutely aware of any symptoms and signs. So we're all looking forward to update what we and when we should actually refer to cardiologists. And in a second session, we'll hear from Piers Patton about clinical trials in CLL. So now I would like to hand over to George, who will chair the first part of the session.
Thank you very much, Renata. So good evening, everybody. This is the third of our UKCLL Forum teaching sessions on CLL. And for this last session, we've decided to move a bit left field and actually go into a different specialty, namely cardiology, as Renata said. Now, with our drugs, which are having a bit of an impact on the heart, and with our patients who are living longer, of course, we are straying more and more into the cardiology field. And there's ever more pressure for us to develop relationships with our cardiology colleagues. And in fact, for the cardiologists, become specialists in the new specialty of cardio-oncology. So this is where Professor Charlotte Manisty comes in. Now, Charlotte works at Barts in the London Cardiology Centre. And as we all know, those of us who work in this part of the world, this is an enormous cardiology service. And they have the biggest cardio-oncology unit in the UK. And if you've ever listened to our good colleague John Gribben talk, he tells us how amazing the service is, and we all get completely jealous about this, Charlotte. So just to let you know, when it comes to questioning, we're going to be a bit green around the edges because of the service you're able to provide our CLL colleagues at Barts. So I think without further ado, I'm going to hand over to Charlotte, and I'll drop into the background and then come back on to chair questions. Just for the delegates, remember, question and answer sessions there. Please do put your questions, so which will help us having our debate in about 40 minutes time. Thank you, Charlotte. Handing over to you.
That's brilliant. Thanks so much, and thanks for the introduction. And apologies for not having the video on. I'm just a bit worried that my internet connection may not be stable enough, so apologies for that. So I would call this a cardiology class rather than a masterclass, but hopefully I'm going to give you a fairly broad flavour of different areas where we need to think about cardiovascular considerations in our haematology patients. And I'm very lucky to be supported by great haematologists where I work. And therefore we see a broad spectrum of patients, and they really help me with the care of my patients. So I probably don't need to tell this audience that actually cardiovascular disease is the leading cause of premature morbidity and mortality in those patients who survive 5 years for breast cancer and lymphoma. And that's partly because of changes in survival, but also because of risk factors that are shared between many cancers, including hematological malignancies and cardiovascular disease, and also because of the new therapies that are coming through, many of which have unexpected and unwelcome cardiovascular side effects. This is actually a really old slide, as you can see now, in terms of the bottom right data, but it's always quite sobering to show cardiologists this, where you see the new drugs coming through in development in yellow along the bottom for cardiovascular, and then obviously in terms of oncology and hematology it's gone up, but in hematology it's now shot up in recent years. So that's really quite sobering, and the new therapies that are coming through. But really what our aim is as cardiologists is to try and prevent this. This was a patient's echocardiogram 6 months after anthracycline chemotherapy for lymphoma, and that was before anthracyclines. And when we look back and saw what we could have potentially done better, and this was a patient who was treated before we had our cardio-oncology service at Barts, we could see that actually, obviously, this lady was at quite high risk. She had multiple cardiovascular risk factors. She was obese, a smoker, CKD, etc. And actually, there's a lot we could have done to change her outcome. So first of all, we could have optimized her cardiovascular risk factors. And more importantly, perhaps we could have monitored her very closely throughout the treatment, and perhaps considered alternative cancer therapies, and perhaps administered cardioprotective agents to try and prevent this happening. So really what we're trying to do is to improve outcomes of cancer patients, not only by improving their cardiovascular outcomes and trying to prevent cardiovascular events, but perhaps also by ensuring that if we optimize them from a cardiovascular perspective, then that enables you as haematologists to be able to deliver the best possible cancer therapies to get the best possible cancer outcomes. So really, cancer and cardiovascular outcomes are fairly intricately linked in this kind of scenario. So where does cardio-oncology come in? Well, it's really throughout a patient's journey, both pre-treatment, during treatment, and after treatment. So pre-treatment, you're probably often asking cardiology colleagues to help risk stratify patients before having potentially cardiotoxic treatments. And that might include assessing patients with known cardiovascular disease, investigating patients who've got cardiac symptoms, and also for particularly cardiotoxic therapies, getting a baseline with which we can compare subsequently during treatment if patients are due to be monitored. But perhaps in practical terms, what it also helps do is guide cancer treatment choices, guide what monitoring we're going to do for that patient during their treatment, and also guide administration of cardioprotective treatments. And then obviously during and after treatment and late into survivorship, there's importance for surveillance for cardiotoxicity, and there are all kinds of cardiotoxic effects that can happen as a result of cancer treatments, and that includes obviously the hem-onc treatments as well, but also investigation and management of toxicities that arise. And then alongside that, in the cardio-oncology service, we look after patients with AL amyloidosis and also any patients who have cardiac masses, either related to their treatment or associated with that underlying malignancy. So one of the things we try and encourage is the thought that you need to consider cardiovascular implications throughout a patient's journey, as I said, both in terms of before treatment, during and after treatment, but also importantly to risk stratify all patients, because every patient is obviously not going to be at the same risk. And we now have lots of guidelines out, both from oncology associations, but also perhaps most importantly from the cardiology associations that have come out in recent years. And the 2022 guidelines here which were published in 2022 in association with the European Haematology Association, have given us a very, very clear footprint about how we should be managing these patients. So what are the aims of the guidelines? Well, it's really a single document that's ideally going to assess all healthcare professionals, so both haematologists as well as cardiologists, and ideally primary care. And there's also actually a patient guideline associated with this, so that all of the guidelines are almost translated into lay language to ensure that patients are able to understand the implications from a cardiovascular perspective of their treatment. It's specific to the oncology and hemato-oncology population. It gives us established definitions of toxicity. It gives us recommendations, and it also gives recommendations for individual European Society of Cardiology guidelines. But most importantly, and at the heart of this, it's a multidisciplinary document. And so that's really kind of crucial. What it highlights, again, as I said, is the risk stratification of patients. So it's going to how you manage a patient in terms of baseline assessment, surveillance during and after treatment will depend on what the patient's baseline risk is, and then also the treatments that they're going to receive, because obviously the same will not be the case for every patient receiving every treatment. And they give quite clear, quite nice pro formas such as these, suggesting what investigations should be done in what patients dependent on their baseline cardiovascular risk. Now, for the ESC guidelines, and you'll see a few of these kind of schema throughout this talk, anything that's got a class 1 indication is in green. So class 1 indication in ESC guidelines means this is what you should be doing for your patients. Class 2A is what you should consider doing, and that's in yellow. And then the orange ones, class 2B, are where you may consider doing it. So certainly all class 1s really is what we should be doing. And then we probably should be doing the yellows, and the blues are something that you could consider if you wanted to. And I suppose the important point is that all patients should have some kind of baseline risk assessment done. That's generally just a history, basic examination, looking for any previous cardiovascular history, but also measuring their blood pressure and ideally measuring baseline risk factors, so lipids and HbA1c. And if you've got a low risk patient that's due to start with a low risk treatment, then that patient can just go through their cancer treatment and not need any additional involvement from cardiology. But in patients who are due to receive higher risk treatments, there are specific recommendations dependent on the risk in terms of monitoring that's needed throughout. And there are these schemata, for example, for anthracyclines, and then you'll see there's one for the BCR-ABL TKIs, the myeloma proteasome inhibitors, stem cell transplant patients, etc. And they give quite good recommendations about which patients need what investigations and when during their treatment. And that goes late into survivorship as well. So when we think about that baseline risk assessment, as I said, it's thinking about the history, what previous cardiovascular problems they've had, their blood pressure, HbA1c, and cholesterol. And then in some situations, it would be recommended that patients have a troponin or NT-proBNP. And again, ECG probably in most patients, and echocardiogram, particularly in high-risk patients. And as I said, those patients who are designated to be low risk can basically go on and start treatment without involvement of a cardiologist. But patients who have got either symptoms at the time of diagnosis and starting treatment, or who've got pre-existing cardiovascular disease or at high risk, probably need referral to a cardiologist before they start their haematological treatment. And in some situations, it probably will need specialist cardio-oncology involvement. One of the advantages, and I'll talk a little bit about this later, of having a cardio-oncology service is we do tend to see the patients very quickly. We kind of work along cancer timelines. And so we expect to do all the investigations, assess, and give a decision within 2 weeks of referral, which is often quite difficult to deliver in general cardiology clinics. So the other thing that the European Society of Cardiology has produced is this baseline risk assessment tool, which really gives quite nice little calculators as to how to assess your patient's baseline cardiovascular risk. They've got this little app on the ESC Pocket Guidelines app. And even though you may be loath to download something that's cardiology based, it's actually quite useful even for a general medic. It basically gives little calculators which you can type in each of the individual patient's risk factors, etc. And that's according to the individual cancer treatment that the patient is going to receive. So, for example, it gives you everything from multiple myeloma with baseline risk assessment to VEGF inhibitors, but it also has lots of other things like CHADS2 VASC score, equivalence dose for anthracyclines, etc. So it's actually a really useful tool, and it's free. You can just get it off the App Store, and I would strongly recommend it. And actually, we now try and use this as much as we possibly can for baseline risk assessment of our patients. So as you can see, this is an example on the right. This is the one for long-term surveillance and asymptomatic cancer survivors. And you basically can type things in and it gives you a risk and tells you what you should be doing with your patient, how often they should be having echocardiography, for example. So it's actually quite a useful practical tool. So obviously most of these sessions are about CLL. So I'm going to cover some of the cardiovascular effects of CLL therapies first of all. And many of you will be very well familiar with the relationship of atrial fibrillation and ibrutinib. We know, of course, it's the most common cardiovascular toxicity associated with ibrutinib that leads to drug discontinuation. There are other side effects, but it's less likely to cause discontinuation. And actually, the incidence from the meta-analysis of clinical trials, it's about 6%. But I think real-world data is significantly higher, and certainly my experience feels significantly higher than that, although probably I don't know what the denominator is, but I see a lot of patients with it. The median time of presentation is about 3 to 5 months after treatment initiation, but it continues to rise with prolonged exposure. And we have seen patients developing atrial fibrillation a year, 18 months into treatment. The risk factors are the ones you'd expect if a patient's older and they've got pre-existing cardiovascular risk factors, or particularly if they've had prior paroxysmal atrial fibrillation, they're at much higher risk of developing atrial fibrillation on ibrutinib. But also importantly, if you stop ibrutinib, about 60% of patients will go back into sinus rhythm and not require further treatment of atrial fibrillation. So I suppose one of the changes in the last couple of years has obviously been the ability to be able to change patients to an alternative BTKI if the patient develops atrial fibrillation. And we're obviously starting to do that much more. And that wasn't an option previously, and that's great. But it's not just atrial fibrillation. You'll have seen many patients who develop hypertension as a result of ibrutinib, and those patients need to be treated and managed relatively aggressively to ensure their blood pressure is relatively well controlled. We know that this is less likely to happen with ibrutinib, but still, without ibrutinib, it still does happen. Ventricular arrhythmia is again more common with ibrutinib. And heart failure, although rare, can happen in patients taking any of the BTKIs, but ibrutinib most commonly. And these patients, we certainly should be considering holding the BTKI if they've developed heart failure, because that can be less reversible. One of the challenges, as you will commonly have experienced, is of managing medications that we give to treat atrial fibrillation if we're continuing the ibrutinib. We've got lots of different drug interactions, and we know that giving calcium channel blockers is potentially risky due to increasing plasma levels of ibrutinib, so we tend not to use those. Digoxin, again, you can get digitoxic as a result of giving digoxin in association with the ibrutinib, and amiodarone we do not give either. So you're often left with relatively limited treatment options, and we generally rely on beta blockers for these patients. As you also know, there are problems with effects on platelets for ibrutinib, and therefore we need to be a little bit careful in terms of administration of anticoagulation in patients. And so we certainly do not give anticoagulation to patients who have a CHA2DS2 VASC score of less than 2. So we reserve it for patients who have a CHA2DS2 VASC score of 2 or above. Our patients who have 0 or 1, we tend not to give it. And actually, we often give apixaban 2.5 milligrams instead of 5 milligrams, simply because of the risk of bleeding associated with giving ibrutinib with the factor Xa inhibitors. But of course, I don't need to tell you that not all BTK inhibitors are equal, and obviously we've seen significantly better survival with zanubrutinib as compared to ibrutinib, but we've also seen significantly reduced cardiovascular side effects, and that's really great news. And we've seen that both with when we compare the cardiotoxicity of ibrutinib with acalabrutinib and with zanubrutinib, the rates of atrial fibrillation, hypertension, and ventricular arrhythmias are lower with the newer BTKIs. So again, as I said, ideally when we're managing these patients, we would want to be careful with the medications that we give in terms of drug interactions. We tend not to give warfarin. And for patients who have got hypertension, we try to treat that relatively aggressively using non-ACE inhibitor drugs in the first instance if possible. And as I said, if patients develop heart failure, we would ideally stop the BTKIs if possible. In terms of why there are different cardiovascular side effects, well, we've got different kinase targets of the different drugs, and it's really the CSK, the C-terminals SRC kinase target that seems to be the one that we think is predominantly responsible for the cardiovascular side effects related to ibrutinib. And that seems to be because of a kind of inflammatory reaction and effects of fibrosis and left atrial enlargement in patients taking the ibrutinib. So that's kind of the BTKIs and a very brief canter through, but I'm just going to move on to some of the other hematological therapies given and their relationship with cardiovascular side effects. So CML, you will have a small population probably of patients who you treat with CML, and you will know that the life expectancy now is excellent as a result of the BCR-ABL TKIs. So now we know that actually the survival in patients with CML is predominantly determined by their comorbidities rather than their underlying CML. And so it's really important that we try and optimize comorbidities and reduce cardiovascular side effects as a result of the BTKIs. Sorry, the BCR-ABL TKIs. So when we're thinking about patients with CML, the other thing to recognize is that most of them have comorbidities at diagnosis. So if you look at the number of patients with hypertension or cardiometabolic comorbidities at diagnosis, you'll see that almost half of them do. So this was a population-based registry of patients across 20 European countries, and you'll see that the majority of patients had some cardiometabolic comorbidity at diagnosis. And actually, when we look at how that translates into cardiovascular risk, and here we use something called the Framingham 10-year cardiovascular risk score, which gives you the 10-year probability of developing a major cardiovascular event, you'll see that nearly 40% of patients at diagnosis of CML are either at intermediate or high risk of having a major coronary or cerebral event within 10 years. And actually, when we compare the CML population with the general population, this is US data you'll see on the right here, you'll see that actually cardiovascular risk is higher in patients with CML than their age and sex match peers within the population. So this is already a high risk population, even before we give them any drugs. So this here on the left is a schema from the European Society of Cardiology guidelines, which highlights the different cardiovascular toxicities that you can get as a result of the first, second, and third generation BCR-ABL TKIs. And you'll be very well aware that each of the drugs has a very distinct pattern of cardiovascular side effects. Most of them are associated with hypertension, apart from imatinib, which, as you'll be aware, is probably associated with lower cardiovascular risk even than placebo. But when we look at drugs like ponatinib, you'll know that there are very, very high rates of hypertension. So greater than 10% of patients develop significant hypertension, and they also are much more likely to develop arterial thrombotic events and peripheral vascular disease as well. So each of the different TKIs is associated with a different pattern of cardiovascular toxicity. And it's important to think about when you're making choices of hematological therapies to give your patients with CML, and the balance of their pre-existing comorbidities and side effects need to be considered. So we know that obviously cardiovascular risk is associated with the BCR-ABL TKIs is highest in patients who have already got pre-existing cardiovascular risk factors. But I think the important thing is that patients who are taking nilotinib or who have got pre-existing cardiovascular disease, you should try and avoid nilotinib and ponatinib if possible, because those are the drugs that are particularly associated with coronary effects. And patients who have got pre-existing lung disease or any risk of pulmonary hypertension, you should avoid dasatinib, which is associated with pulmonary hypertension, pleural effusions, and pericardial effusions. So again, when we look at this is an example of the little calculator used for the BCR-ABL TKIs. And you can see here that this is, for example, patient I've put in. You can type in whether they've got each of these different comorbidities here, and then it gives you a risk. And so certainly if you were getting a patient where it's saying the patient had very high risk, you would want to avoid giving that patient ponatinib or nilotinib, and you probably think about the other BCR-ABL TKIs. When we think about what we need to do in terms of surveillance during treatment with the BCR-ABL TKIs, you can see that for all patients in green, it's recommended that they have a physical examination, blood pressure, ECG, and then lipids and HbA1c at baseline. And then for patients who are due to start dasatinib, they should also have a baseline transthoracic echocardiogram. And that's really to pick up pulmonary hypertension, pre-existing pulmonary hypertension, or also to give you a baseline with which to compare should your patient develop problems and shortness of breath further down the line. Now, I've often been asked by haematologists, does that have to, how feasible is that to get before the patient starts treatment? And I think what I would say is it doesn't have to be absolutely before the patient starts treatment, but it needs to be early on so that we've got something that can more or less be a baseline. So just looking at the BSH guidelines for CML, what it recommends here, it really recommends that you think about comorbidities when you're choosing your second and third generation TKI, and certainly anyone who's got significant cardiovascular comorbidities, you should be very careful with nilotinib, and certainly the same is for ponatinib. And when we look at the ELN guidelines, it's really fairly similar, whereby they suggest that anyone with previous or concomitant arteriovascular disease really shouldn't have nilotinib first line or ponatinib second or third line. And similarly with patients with pleuropulmonary disease, be careful about starting them on dasatinib. And then when patients develop complications as a result of their BCR-ABL TKIs, I think here you slightly have to hold the hand of the cardiologist and really give them fairly strict instructions about what CML is, what their prognosis is, etc. For many cardiologists, they will have no idea that CML essentially is associated with an almost normal life expectancy. And they'll hear that the patient's got hematological malignancy, and therefore they may not give that patient the best possible treatment from a cardiovascular perspective. So I've had patients, for example, who have been refused for cardiothoracic surgery because of CML until myself and the hematologist intervened and told them that was absurd. Similarly, the other thing is it's unlikely that your cardiologist will necessarily make that link between their nilotinib, for example, or ponatinib that the patient is taking, and the coronary event. And therefore, you need to ensure that there has been a discussion about interrupting or discontinuing their treatment, because often I've seen patients discharged despite having had an ST elevation myocardial infarction, still taking their nilotinib, which is not ideal. I'm going to give you a quick gallop through anthracyclines, because probably most of you are well acquainted with this as they've been around for so long. We know that they're associated with left ventricular systolic dysfunction and heart failure in a relatively small proportion of patients, although asymptomatic left ventricular systolic dysfunction is much more common. All of the data really out there about incidence of anthracycline cardiotoxicity is very outdated. It's based on patients not having any surveillance during their treatment. It's based on higher doses of anthracyclines. And so actually probably modern incidence is much lower than this. But we also know that there's differences between the different drugs, and you kind of need to consider this really when you're thinking about drugs and obviously trying to minimize dose as much as possible, because we know it's dose dependent, and we know that certainly if you're having other potentially cardiotoxic therapies such as radiotherapy alongside anthracyclines, it puts you at higher risk. So patients' risk is dependent not only on the cancer treatments that they're due to have, but also what their baseline cardiovascular risk is and what their risk factors are. So, for example, this is obviously data from breast cancer, but we can see that on the left, patients who are receiving anthracyclines who have more than one cardiovascular risk factor are at much higher risk of left ventricular systolic dysfunction than patients who have no cardiovascular risk factors. So just to very quickly give you a very simple example of how the ESC risk calculators work. So this is a very low risk patient, 38-year-old male with non-Hodgkin's planned for R-CHOP. And if you type his risks in here in the anthracycline chemotherapy risk calculator, you can see that he comes out as low risk, unsurprisingly. And so what does that mean for him? Well, if we then look at the surveillance protocol for anthracyclines and look at a low-risk patient here, you'll see that the patient should have an ECG at baseline, they should have an echocardiogram at baseline, but they really don't actually need anything else particularly, but they should have a follow-up echocardiogram within 12 months of completion of treatment. Now, I know that actually some centres are not doing echocardiograms in their low-risk patients, but I can tell you from my experience that I've had some low-risk patients who have ended up with severe left ventricular impairment receiving anthracyclines. Now, the likelihood is that those patients actually had pre-existing cardiomyopathy before that. I had one woman who's ended up having to have a heart transplant as a result. Probably she did have pre-existing dilated cardiomyopathy, which was then made worse by the anthracyclines. But because she'd been seen and treated in another centre where she hadn't had a baseline echocardiogram, we will never know the answer to that. But certainly, had we known about LV impairment before she started anthracyclines, we probably wouldn't have given her that treatment, or we'd have monitored her extremely closely. And you can see that for high and very high risk patients, they really need to be monitored very carefully during treatment. It doesn't mean you shouldn't give anthracyclines, and we give quite a lot of high risk patients anthracyclines, but we hold the haematologist's hand very closely during the treatment and monitor the patients very carefully. So we may end up doing biomarkers, for example, with every cycle of anthracyclines and echocardiograms every 2 cycles. And really the reason for that is that we know that early detection is key. We know that the majority of patients, if they're going to develop left ventricular dysfunction, are likely to during treatment or within the first 12 months after finishing treatment. And we also know that your likelihood of recovery in terms of your ejection fraction is based on how quickly you're treated. So patients are more likely to recover their cardiac function if they're treated early on, if it's picked up and treated aggressively early on rather than treated late. The other thing we're starting to do a bit more of, although the evidence is a bit shaky, is give drugs for primary prevention of left ventricular dysfunction. And there's obviously things that you can do that are very simple to try and prevent it happening. Obviously try and optimize their risk factors, and that particularly includes their blood pressure. But also there are some drug trials, and I'm kind of a bit hesitant about it, suggest that giving ACE inhibitors or beta blockers concomitantly with the anthracycline treatment in high-risk patients may reduce the risk of developing subsequent left ventricular systolic dysfunction. Dexrazoxane we have given to some patients being treated for breast cancer who have had previous treatment with high doses of anthracyclines for lymphoma, for example, and certainly they're using dexrazoxane quite a lot in the pediatric oncology community. And liposomal doxorubicin we know has a slightly lower risk of cardiotoxicity than standard doxorubicin. And then there's some recent therapy studies showing that statins may have some benefit for primary prevention in this setting. Although, to be honest, there's now been 4 or 5 quite big studies, and there's been conflict in the results. But there's a suggestion that in high-risk patients who are due to receive higher doses of anthracyclines, that giving them a statin may prevent cardiotoxicity. If your patient does develop cardiac dysfunction during their treatment, they must be managed as per normal current guidelines for heart failure. So your cardiologist should be able to manage these patients really fairly straightforwardly using standard guidelines. But the MDT discussion is central to all decisions. And that's a really important thing to say, because the treatment has to depend not only on how you're going to manage their heart failure, but also what you're going to do in terms of discontinuing or continuation or interruption of their anthracyclines. And that will be a combined decision between the haematologists and the cardiologists. And we as cardiologists would never make that decision on our own, because it's going to depend on what the patient's prognosis are, what the alternative agents are, etc. And so we certainly would want to do that in an MDT setting. But if anthracycline has to be continued because there are no other valid options, and the patient has only got mild asymptomatic left ventricular dysfunction on their echocardiogram, then there are things that we do tend to do to try and prevent that getting any worse. So myeloma, we see a lot of myeloma patients, partly because they're older, partly because they've got a lot of cardiovascular comorbidities pre-existing, and they also have other things that are related to their myeloma, renal impairment, anemia, hyperviscosity, etc., which make them much more likely to develop cardiovascular problems. But then, of course, many of the therapies are also associated with problems. And again, similar to many of the other drug classes we've talked about, the drugs have different cardiovascular side effects dependent not only on the class. So we know that proteasome inhibitors are probably more likely to develop problems, for example, than some of the newer therapies. But even within the class, we know that different drugs have different side effects. For example, we know that carfilzomib has much higher cardiovascular side effects than Velcade does. So about 22% of patients taking carfilzomib are known to develop cardiovascular complications, and it's thought that this higher risk related to carfilzomib as compared to bortezomib is related to the fact that you get an irreversible binding rather than a reversible binding, which you would get with Velcade. Most of the cardiovascular side effects seem to happen relatively early within the treatment, and therefore we do ask that patients be risk stratified before starting treatment, and those patients who are high or very high risk, you might consider an alternative therapy. So this is an example patient, a 67-year-old man with pre-existing cardiovascular disease who presented with some shortness of breath and ankle swelling and was diagnosed with IgG lambda myeloma. He was planned to have Dara-VCD for his treatment, and again, this is from the ESC guidelines. You can then look and see what the potential risk factors are associated with, the potential cardiovascular complications associated with these drugs. And here with bortezomib, the risk is not that significant, but patients are more likely to develop hypertension. With daratumumab, again, they're even more likely to develop hypertension, but the other cardiovascular side effects, not too bad. We then have a risk stratification tool that tells us how we should be monitoring our patients both at baseline and during therapy. And obviously this patient was at high risk because he had pre-existing cardiovascular disease. And so it recommended that he should have biomarkers done at baseline and an echocardiogram. He then had his ECG, his biomarkers, and his echocardiogram. And I don't think you probably need to be a cardiologist to be able to tell that it was quite clear that he had cardiac amyloidosis. So he had very raised cardiac biomarkers. He had the small ECG signals. He had left ventricular hypertrophy on his echocardiogram, as well as right ventricular hypertrophy. And then when he had a cardiac MRI scan, it was completely diagnostic of cardiac amyloidosis. So just very quickly, we treat a large proportion of patients with AL amyloidosis, and we have mixed outcomes, as I think is common in the UK, where patients are often diagnosed very late. He was stage 2, so median overall survival of 40 months, and he started and continued on his treatment with DARA VCD. Importantly, for all of our patients who are diagnosed with AL amyloidosis with cardiac involvement, we initiate their treatment as an inpatient on a cardiac monitor. We give quite a lot of them amiodarone as a prophylactic empirical drug, depending on what their QT interval is. And certainly we would keep them on a monitor for the first 72 hours during their initial part of their first cycle of Velcade. Because it's in that time that the patients tend to develop the ventricular arrhythmias. We were giving doxycycline to all of our patients. I think the evidence is kind of equivocal there about whether it's effective or not. But all patients would have a Holter monitor before they start treatment to look at the risk of arrhythmias, etc. Just quickly, in terms of how the organ involvement works with AL amyloidosis, we know that the clearance is slow over months to years. And ultimately what we're trying to do, obviously, is to try and decrease the deposition and ensure that the body is able to kind of clear the amyloid as much as possible. And we know that clearance in vivo is slow, and you'll get different rates of clearance between the different organs and between different patients. We now have imaging techniques where we're able to essentially measure the amount of amyloid within the heart using cardiac MRI, so we can actually track amyloid regression within the heart. And we know that if patients have a complete hematological response to the DARA VCD, then their chance of regression of their organ involvement goes up significantly. And if patients don't have good regression, then it's much less likely that they're going to get organ clearance. I'm aware that I'm running a little bit low on time, so I will just quickly flick through this to say that, as you're probably aware, there are a lot of treatments now emerging. It's a really active area of research at the moment is new therapies for AL amyloidosis. And there are lots of treatment strategies now available where you're not only trying to eliminate the plasma cell clone, but actually trying to disrupt amyloid formation or actually even remove the AL amyloid deposits from tissues. One of the things that patients often are confused about is that we're not actually getting the amyloid out of the heart. That's what they always ask me, how's the amyloid going from the heart? And they don't realize that actually we're not actually removing it with the chemotherapy, we're just stopping further being laid down. I'm going to flick through stem cell transplantation, and I'm just going to go to radiotherapy. Radiotherapy, as you know, the late effects are dose dependent, and they're also going to be partly dependent on what other treatments the patient has had. It's important to say that when patients develop symptoms late after radiotherapy, it may be due to a multitude of cardiovascular side effects, and they can actually all happen together. So you can get patients who present with coronary disease, arrhythmias, valve disease, and pericardial disease, even all at the same time. And we also know that the patients are much more likely to end up needing cardiovascular intervention than patients of their age and their peers. So we as cardiologists, when we see late effects patients, either as a result of stem cell transplantation or of radiotherapy, we need to assess them as a whole because there may be multiple different parts of the cardiovascular system involved. The other thing is that from our perspective, if we need to do any intervention on patients who've had prior radiotherapy to the chest, we know that their outcomes are worse. So we know that the outcomes in terms of survival following coronary artery bypass grafting or PCI are going to be significantly worse if the patients have pre-existing radiotherapy. And that's partly because of calcification, and it's partly because of all the other effects that you can get as a result of high-dose mediastinal radiotherapy. So just a couple of summary slides to finish. I think the one thing I'd like to kind of try and emphasize is that we do very much work as a multidisciplinary team, and we would never make decisions about cancer treatment. They're always made by the treating hematologist or oncologist. Our aim is actually to try and get patients to be on the best possible first-line cancer treatment. So often we would end up taking a patient where perhaps the haematologist might not have given a patient a anthracycline. They might not have sent that patient for stem cell transplantation, but we are perhaps more confident in managing the potential complications that might arise. We're happy to do quite close surveillance of those patients. And so patients are probably more likely to have more aggressive hematological management than they would without our input. And as I said, all of the decision-making really is based on the input from the hematologist about what alternative therapies might be available and what the treatment aims and prognosis of that patient are. And that is both cardiovascular and cancer-based, and also involving the patients. We've got lots of evidence gaps. Our guidelines look fantastic, and there are 272 new recommendations in these ESC guidelines. But you'll see that the majority are actually supported by fairly weak evidence. So we've got our work cut out in terms of producing the evidence to support the guidelines, or indeed refute them and change them. But we have quite a problem, because most of the data collection is from retrospective real-world data rather than the clinical trials. Clinical trials tend to exclude patients with pre-existing cardiovascular disease. They collect very poorly baseline cardiovascular risk factors. So it's very difficult to try and determine whether a patient's cardiovascular event happened as a result of pre-existing cardiovascular disease or risk factors, or whether it was completely unrelated and related to the drug. And the other thing is that endpoint collection in terms of cardiovascular endpoint collection in the clinical trials is really poor. The CTCA data points are very bad for cardiovascular disease, and it's difficult to try and distinguish between what might have been a heart failure event or what might have been an ischemic event, because they can be classified in all kinds of different ways. The other thing, of course, is you've got so many new therapies coming along that we can't really keep up. And so trying to get long-term data on these newer therapies and all of the therapies that are coming along, CAR T therapy, etc., we're trying to play catch up. We're trying to help you, but it's difficult because you move so fast. Our program, just very quickly, this is an example cardio-oncology program. We've got 4 consultants that work in it, although to be fair, we've actually only got the equivalent of less than 1 full-time equivalent consultant. We run one and a half clinics a week, and our clinics are all one-stop clinics. So patients will all have imaging done at the same time as being seen by a consultant. And actually, we run our clinics in the same location where the myeloma clinics are held, because we have so many myeloma patients and amyloid patients that come through that we often end up seeing patients together. So all our new AL amyloid patients will be seen by a haematologist and a cardiologist together in the same clinic room. We also provide limited inpatient cover, and we have an MDT every week. And in that weekly MDT, we'll have patients sent from other trusts, and we will ensure that there are cardiologists as well as the patient's treating hematologist or oncologist present. And we also have a monthly MDT. We have 2 CNSs, and we have subspecialty consultants who are particularly interested in cardio-oncology for both EP and intervention. You'll see that actually the biggest chunk of our patients are hem-onc patients, and we did nearly 1,500 consultations last year. So we're kind of growing, and we're a big team. So we've got all of the people involved on the cardiovascular side. We've got hematology consultants. We've got solid tumor consultants. But essentially, as you'll be aware, many cancer treatments are associated with cardiovascular problems. But what I would urge you to do is to try and do baseline risk stratification and refer on to a cardiologist for optimization of their cardiovascular status, because we will improve cardiac outcomes. Multidisciplinary working is key, and try and find a friendly cardio-oncologist. We're there to help as much as we possibly can. Those are the guidelines, and anyone who's interested, BCOS is a small fledgling organisation which we're trying to expand. So thank you.
Thank you, Charlotte. That was an absolutely fantastic tour through cardio-oncology. And I did say I'd start off sounding a little bit green, because you provide an incredible service. And I was just seeing that 1,500 consultations led by a consultant in a year, and you've got your specialist cardio-oncology nurses, etc., etc. That's something for us to aspire to, because I looked at those things: baseline echoes in low risk, echoes at 12 months post-treatment. I don't think we come anywhere near meeting those basic requirements. I'm pretty sure centres are going to be closer to what we're doing than what you're doing. So yeah, that's something we do need to move towards, because I can see all of the very positive sides that you flag up. And I think your point that actually cardiotoxicity found early is a toxicity either prevented or minimized. And I think that's something that we all get reminded about from time to time with patients, particularly anthracycline-associated late toxicities. And we think, oh my goodness, could that have been cut off at the path? Now, I've got quite a lot of questions I've come up, but we've had a bit of chat coming through from Piers and Renata, lots of good haematology questions. So I'm going to start off with a few. I really latched on. You said, well, actually, a apixapan dose or DOAC dose in our patients on BTKIs. So this is a problem for us in the day-to-day clinic. They've got atrial fibrillation. I know when moving away, we tend to just move them off ibrutinib if they're CLL patients, but, you know, mantle cell patient, we might not have that choice. And I intuitively, so apixaban, I'd start them on half dose, 2.5 milligrams BD for a month to see whether they got nosebleeds, mouth bleeds, skin bleeds, because some patients are bleedy and other patients are not. We know that with BTK inhibitors, it's hard to predict. But I've always been told off by my general medical colleagues that actually stroke prevention, you need the full dose of the DOAC. And yet you said, pragmatically, we might just have to give them half dose. I loved hearing that from a cardiologist. Is that backed up by any evidence, or?
So I think it's what most of us tend to do, but I'm not sure how strong the evidence is to support it. I mean, I suppose I've been slightly burnt recently with a patient who developed a hemorrhagic tamponade and needed drainage, and they were on full anticoagulation. I suppose, yeah, I can see as a haematologist jumping in who's going to give a much more measured and evidence-based answer. So apologies. I don't. It's what we tend to do, and it's what several other papers looking at BTKIs and AF have suggested. But I don't know whether that's actually particularly evidence-based. But certainly in terms of risk, I think the stroke risk is relatively low in these patients because of the platelet effects of the BTKIs. But I don't really know. Sorry, that wasn't a very helpful answer.
No, but also the point, sorry, Peter, just the point that actually the ibrutinib might increase the circulating effective dose of the DOAC. And I've been slightly aware of that as well, because it's this uncertainty of these interactions. And that's why pragmatically I take the views, if you say there's a 7% annualized risk of stroke with AF, so for the next month, what is their true risk? Running them at half dose, are they a bleeding patient, and seeing how we get on just seems a pragmatic start. But Piers, you were going to interject.
Well, actually, no, only because I got told off the other day by a cardiologist when I said, when someone was very hemorrhagic, that, well, they're getting good antiplatelet effect along with their DOAC, but they said, no, absolutely got nothing to do with the prevention of stroke risk. So I was a bit surprised by that. But...
I'm not sure.
Okay.
About that,
Let's move on. Now, it's an atrial fibrillation question. So if you said that 60% of them stop. So I'll give you an example. I've got a patient been on ibrutinib, one of my few that stayed on ibrutinib for many, many years, and then they had a drop attack, that feared thing. Your message comes through from your nurse that, Aunt Nellie had her drop attack yesterday. So we put on the tape, and lo and behold, she was getting paroxysms of AF, but also had a very frightening run of VT hidden away. That was actually quite asymptomatic for her. So I stopped the ibrutinib, we've put her on anticoagulants, and the cardiologist has rightly said, well, look, why don't we just I'm leaving her off all treatment for the time being, and we're going to repeat the tape in 3 months. If there's no AF, you can decide whether or not you want to carry on anticoagulation, because the ibrutinib will be long gone. Well, I was thinking to myself, it's a really difficult question, that, because presumably the ibrutinib was a major stimulus in this 70-year-old with no cardiac history.
Yeah, it's difficult, but 70-year-olds with no cardiac history also develop AF even without the ibrutinib. So it is difficult. I mean, I think that's actually when I involve patients. So if she was a woman and she was 70, she's kind of, and no other risk factors, then her Chas-2-VAS score is kind of borderline. I mean, she's 2 just about, but obviously the 1 for being a woman is a slightly weaker one. So I don't know. I think probably she would probably have anticoagulation lifelong, but I think if you tape someone long enough who's 70, you're probably bound to find a short run of atrial fibrillation. So I think you could argue it both ways. This is a grey area. I don't think there's much evidence here.
It is so great. And then if you start them on a BTK, you've added to bleeding risks against it. I find these things quite difficult. Now, sorry, keeping it going with other questions. I think, Piers, you had a question about whether if you've had AF on ibrutinib, and you stop it and then put them on another BTK, do we have a feeling? I think all of us as haematologists do feel quite confident that second generation ones have fewer arrhythmia events. Have you seen enough cases to get a feeling whether it's likely to simply recur on the next BTK in your experience, or?
So I think it depends. If they've got a completely normal, otherwise echocardiogram, they've got normal left atrial size, they're not hypertensive, they've got no other cardiovascular risk factors, then it's less likely to. But I think in patients who have got, I've noticed that patients who are a bit overweight and hypertensive and perhaps have mild left atrial dilatation on their echocardiogram, those patients are probably more likely to still have at some point, another episode of atrial fibrillation. But whether they would have done anyway is difficult to know. I feel like the ibrutinib lowers the threshold, and then it's a question of when you stop it, how far back up you get in terms of likelihood of developing AF.
I've had a couple of spectacular heart failures on ibrutinib, and one of them I've been forced to reintroduce acalabrutinib, thankfully with a 2-year venetoclax gap in the middle, and I'm doing echoes every 6 months, and his cardiac function remains preserved. So I do feel the second generation drugs do seem to me so much cleaner than ibrutinib, but I don't know, as an observation. Now, Renata, you'd also put a question in our chat about the different the different antihypertensive drugs. So we used to use ACE inhibitors a lot. We all got a bit frightened because of that correlative statistical association between sudden death and ibrutinib and ACE inhibitors, which we weren't sure whether that was a statistical quirk on that data set. I know the rest of the world, correct me if I'm wrong, Renata, Piers, but the rest of the world are not following that so carefully. But we've moved over a lot towards calcium channel blockers. Do you have a favourite one, antihypertensive, if John Grimm picks up the phone to you?
So probably I would, if they've got no other cardiovascular risk factors and other than hypertension, and I would probably use amlodipine and just use it because it's such an easy drug to give in terms of interactions and things. The other calcium channel blockers, there are drug interactions, but for amlodipine there's not. But I probably would go for that first line. We do use ACE inhibitors, and certainly anyone who's got any evidence of mild LV impairment or anything, we would certainly use ACE inhibitors for other reasons. But if there's an alternative, I'd probably use it second line.
And drugs like
George, I don't think it was borne out in the end. I know that was the concern about the ACE inhibitors but then whether it should be the angiotensin too. But I think
and it was chicken and egg situation, because maybe just these were the very high risk patient already on ACE inhibitors and ARBs. So it kind of what was first. The drugs which caused it, or the patients who were already on drug because they were already high risk.
Yeah, I do get the impression that that's what our international colleagues thought. So I guess we're stressing about it a bit less now. Although genuinely in my clinical experience, I found that when we were able to access acalabrutinib, I had a few challenging hypertensive patients on ibrutinib who were on multiple different drugs. And when I moved patients to acalabrutinib, I was able to drop out antihypertensive drugs. It does seem a lot of ibrutinib effects on blood pressure seem to be ongoing. That debate at UKCLL about smooth muscle tone being higher in ibrutinib patients because of the drive of CBP beta or whatever that transcription factor was. There was some emerging mechanism.
How much support do you get from GPs on this side of things? Because I'm just interested, because it's something certainly in the CML population that we need to kind of handhold GPs more than we would in patients with cardiovascular risk factors without taking the CML drugs, for example. And I'm just interested to hear what your experiences are of primary care kind of partnership for these patients.
It's primary care, well, in the east of England is so variable. We still have some old traditional GP practices that genuinely patients see the same GP and have a good relationship, and then you can work with that. But many others don't have that set up. So in effect, primary care will push them back to us, because CLL is seen as one of those dominant diagnoses in the pyramid. If you've got that on active treatment, then that becomes a key part of decision making.
I think
So
they get.
can I just jump in? So
in
ESC guideline, is there a bit for GPs then?
There is. I mean, the problem is that how the models work in terms of across the European countries is very different. So, for example, some of the late effects management may be done by primary care in certain settings, and in other settings might be done by secondary care, and in other settings it needs to be done in specialist late effects clinics. I think it's difficult, but certainly the one thing I think is really valuable about the ESC guidelines is actually the patient version of it, because it tells them what kind of things they should be asking their primary care physicians to keep an eye on, and what things that are important. I think that's helpful.
Yes, and Renata, I think you made a comment the other week just saying, tell your patients to get a blood pressure cuff. The £20 that they can spend, if they can spend that £20, is a really important healthcare intervention for our patients. Now, we've got a couple of questions in the chat, and Charlotte, we've got your expertise. We really are benefiting from this. Monica has put in, do you have any information yet about cardiac toxicity with venetoclax? Have you picked up anything? It didn't appear in your slides.
I haven't. I found venetoclax really safe, but I've never had any problems with venetoclax, and in fact that tends to be what the patients get put on, from my experience, when they've developed problems. But do other people have? I don't know what your experience is with venetoclax.
No, I guess some of the problems we have is the amount of fluid you have to give patients, or if they're getting antibodies, and if someone has a hypotensive infusion reaction with obinutuzumab as part of that protocol. So cardiac patients, you do have to maintain a caution, I guess, for some other clinical parameters. But I had a patient recently who was getting cardiac dysfunction on rituximab, and we were bouncing that one around. And it turns out there are some case histories of rituximab with a degree of cardiac toxicity, which was a bit new to me. So I guess.
Yeah, so again, I haven't had much in terms of LV dysfunction. What I've had is one patient who developed relatively young, healthy woman otherwise, who developed really profound bradycardias during her index admission when she was given rituximab, which, sinus brady, and actually she was symptomatic with it and hypotensive, and it never happened again, and it was only during the first cycle. So who knows?
Who knows? Now, there's another question, sorry, before we let you go, about mediastinal radiotherapy. And I do also find this quite challenging. And the question from an anonymous attendee, so I can't thank them in person, but how do you quantify mediastinal radiotherapy exposure in a patient with previous anthracycline exposure if you're trying to assess cumulative dose? So I guess what they're saying is, say they've had 200 milligrams of DOT, if they had 4 ABVD and radiotherapy, would you count that more like 400? Do you give it a 2x multiplier or something? Is there something simple?
No, I don't have an answer in terms of simplicity. I mean, it's probably going to depend on what radiotherapy dose they had, therefore what era they were treated in. But there's no kind of simple multiplicative effect, partly because the effects of the radiotherapy are very different. So as you know, the risk of LV dysfunction with radiotherapy is not that great, but it does cause an increased risk of anthracycline-based cardiotoxicity. But it's all the other effects, the coronary disease, etc., that we worry about more with radiotherapy.
Yeah, but the message about the anthracyclines of those of us who run lymphoma practice as well as CLL is really up our alert. Just a really pragmatic one, Charlotte. So we struggle to get echoes, even for high-risk patients, quickly before chemo. If you are low risk and you're wanting to do your best to follow these guidelines, you request your echo, but they have to start R-CHOP because
they have to start R-CHOP. They have to start R-CHOP. I mean, you can start it, and then worst case scenario, would have to change them. But I still would ask that you request it.
1 or 2
exactly.
cycles.
I mean, yeah, if that's all you can get, that's all you can get. I mean, hopefully echo access might improve. There's lots of AI stuff being implemented to try and improve workflows. It's going to take a while to filter into kind of smaller centers, but it will get there, and hopefully therefore as a result the provision of echo will be slightly better. We are very lucky there, I have to say, just simply because we have access to it, and I know that not everyone else does have as much.
Yes, well, I do sometimes think, Riley, that when we're requesting an echo for some of our patients, we aren't wanting the fully complex one that's measuring all the gradients, the valve function. We just want to have a quick look at the
Yeah, so
ventricle.
that is something that's in fact I've got to go give a talk on Friday about abbreviated echo. It's very controversial. The echo diehard kind of people absolutely can't bear the idea of an abbreviated echo, and the rest of the world think that it's got a value.
Well, close your ears, Charlotte, but I nearly bought myself for a couple of $1,000 this piece of kit you plug in your phone and it teaches you in 3 seconds to do left ventricular function. And I thought, well, that'll be quick and clinic, until my sensible self told me I wouldn't stand up in court.
Yeah, exactly. I'm thinking of you standing up in court.
Well, I will sign off with one anecdote from my clinic a month ago. I have a woman whose life has been saved by her high-grade lymphoma because the echo. So she had her high-grade lymphoma, did a PET scan, and the PET radiologist commented on the aortic root looking slightly abnormal. So I thought, oh, better send this woman for an echo before. And so all the emails said, so no, we can't give her any chemo. And so we sent her, and oh my goodness, completely dilated aortic root that had the echo technician rang me and said, this woman, I'm really worried. And swept into the hospital, started on labetalol, and was in Pathworth and had a whole new surgical aortic root within about 72 hours. So apparently she's about to pop. Her life was
Perfect.
saved.
So you've saved her cardiology life as well as her haematology life. That's good.
Well, yeah, she's still working through her chemo, but anyway, I said to her, lymphoma has saved your life. Now, Charlotte, it is top of the hour. I would like to thank you. That's been an absolute blessing for us, having your expertise talking to us in the CLL community. So I will thank you. And I'm going to pass over to my co-chair host, and I'm going to... Nick has joined us. Nick, thank you ever so much for taking over to co-host in my absence, because I now have to sign off and join another meeting. So thank you all. And thank you to the delegates for signing in for this fantastic course, and Renata for organising it, and Lelia, our patient rep, who hasn't been dragged in today to talk about cardiology so far. But I will sign off at that point. Thank you all.
Thank you, George, and thank you, Charlotte.
Thank you.
And just remind you, I've downloaded already ESC guideline. It's amazing. So I think just one take-home message: do at least that. It's really good. So.